My name is Najla Barnawi. Currently, I'm doing my PhD in nursing, and my topic is aiming to developing clinical guideline among circumcised immigrant pregnant women here in Canada. So, of course, I need your help on that, and pray for me, okay? So the outline of this presentation, I'm going to focus on quick overview about like definition of female genital mutilation, types, cultural types of female genital mutilation, and the overview about the cultural context of female circumcision or female genital mutilation, critiquing Canadian movements regarding the current legislation with respect to female genital mutilation, overview about the maternity experiences of circumcised immigrant pregnant women here in Canada, highlighting the gaps between the immigrant women who are pregnant and circumcised with the Canadian healthcare professionals, presenting some strategies for how we can develop actual effective guideline for circumcised immigrant pregnant women here in Canada. Okay. So the types of female genital cutting or female genital mutilation I classified into two types, okay, based on the WHO classification and the cultural classification. This is the WHO classification one. Maybe everybody know about it. Clitorectomy, excision, infibulation, and others. Okay. This is the most important thing, which is the cultural classification. The type 1 and type 2 under WHO classification called within some cultural values as a sunnah or tahara. Okay, it's the removal of the clitoris, which is used in some Muslim strips, such as Egyptian and Indonesian people. And from their cultural point of view, they believe that it has a positive implication for women in terms of physical and sexual health, such as reducing potentiality of having instance urinary infections and some external reproduction infection diseases. Furthermore, the removal of the clitoris, from their point of view, can regulate the women's sexual desire before marriage and enhance their sexual desire during marriage. The second type, which is called under pharaonic circumcision, that include type 3 and type 4, and it's the most extreme type of female circumcision, right? And it's usually performed by African women such as Sudan, Ethiopian women, Somalian women. From their cultural point of view, they perceive this type of FGC provide a cultural and physical protection for the girls by maintaining virginity, like we enforce her physically or protect her physically to be maintaining her hymen. Okay, this is their cultural views too. Okay? Did anybody knows what is the history of female circumcision? Just raise hands. Okay, that's a good one. Let's see if it's proper evidence or not. The history of female genital cutting, actually, it's go back to during Pharaoh's times. There are some Egyptian mummies found that known as a first case in the world have female genital mutilation. A theory of ancient Egyptian origin of the practice is the premise of the beliefs at the time of the pharaohs in the sexual duality of the soul. Like some Egyptians believe that every man have a female side and every woman have a male side. So excision is important for their point of view to just remove this side in each body. That's the like an old original religious cultural background of female circumcision. The terms pharaonic circumcision originated from the historical background, like from pharaohs of ancient Egyptian performed similar operations on their women. Whether the pharaohs actually infibulated their women or not, we are dealing with a cultural phenomenon of a great antiquity, regardless of the type. we can keep this in our mind that we are not talking about just a belief or a value. It's a cultural iniquity things. We need to keep this in our mind, which is make it hard for us to change it easily, right? Those people who are circumcised, or women who are circumcised in the African countries, in Egypt or in southern part of Egypt or something like that, most of them are slaves, okay? And they sold, right? And the women who are circumcised, they have a high price. They are so expensive because they are called or stigmatized as virgin, okay? We can conclude that the FC is a custom and a taboo carried from one generation to another, right? Only senior females have authority to decide when, who, and how this procedure will be performed. However, the girls to be circumcised do not have any right to choose or know why they having such performance, right? For this reason, FC is a silent practice which should not be discussed outside the family and only among the females within the family. That's make it harder for us to open such a question for circumcised women. So why do you think FC is a cultural silent practice? Because of the sensitivity of that place. This is number one. Number two, it's a forbidden, like in most Middle Eastern countries, like in Egypt, and correct me if I'm wrong, okay? In Egypt or many Arabic countries, they cannot speak about this area, even within with females, except like senior females within the family. So it's a forbidden thing to be discussed in most of Arabic or African cultures. This implies the mother to remain silent about any issues related to her daughter's genital organs and to teach her daughter likewise. Consequently, the mother will only consult the girl's grandmother, her own mother, okay, about the best practice for her daughter. The procedure is a means of maintaining the daughter's virginity, as the closure of the vaginal opening prevents the girl from losing her hymen. Thus, the mother is usually more concerned about this side until the daughter's gonna be married. Then she's safe. So, FGC is not related to specific religion. Agree? Okay. Not only practiced within African communities. Agree? Perfect. It's used as a gender identity, but it doesn't mean that it's a compatible to male circumcision. Agree? Okay. It is a value and beliefs rather than it's a practice. Agree? Please, yes. Okay. So now I'm going to talk a little, I covered a little bit about the cultural components of female genital mutilation. Currently, I'm going to talk about the Canadian FC rules and legislations about female circumcision, okay? And I classify it to two types, governmental and non-governmental. The governmental, which is a federal governmental FC legislation, in December 1995, FC was labeled as a crime under Bill C-119. And it's shown under the criminal code. The bill was reviewed in February 2nd, 1996, by the Minister of Justice, and he indicated that there is a need to reintroduce a new bill regarding FC performance to resolve the high number of circumcised cases within Canada. In May 1997, the same FC federal legislation was maintained despite the increasing the number of circumcised immigrant women. The Federal Interdepartmental Working Group on Female Genital Mutilation was formed to examine the effectiveness of educational materials in improving the public and professional awareness about the complication of female genital mutilation in Canada. In 1995, the same agency sponsored consultations in Ottawa and Montreal with some community members whose countries practice FC. The recommendations of this consultation showed there is a need for sensitive and effective measures to be taken by the federal government to ensure eradication of female circumcision in Canada and to ensure girls and women are protected from such dangerous practice. Ontario established FGM Prevention Task Force in 1994 to address the lack of coordinated efforts between the professionals and institutions. Also, it addressed the need for a consent policy regarding FC performance within Canada. Accordingly, under the supervision of the Ontario Women's Directorate, the Task Force development guidelines and recommendations regarding FC education and prevention within Canada. These guidelines were directed to, first to all, Ontario police officers on October 7, 1994, and second to Crown attorneys on October 12, 1994. This one is non-governmental movement, not a federal policy, okay? College of Physicians and Surgeons of Ontario released policy number 201, which supports the federal FC legislation or policy, and this policy was supported to be reviewed by the college again in 2004, but if it was, no changes were made. Women's Health and Women's Hand hosted a workshop in Ottawa in June 1994 regarding FC performance in refugees. The workshop concluded with the 6 recommendations to eradicate female circumcision performance within Canada, particularly in Ottawa. I'm right? Okay. The second recommendation requested that the Criminal Code of Canada be modified in terms of FC identifications and to explore possibility of new legislations. Department of Public Health in Toronto made a major effort in developing educational materials regarding FC among Somali immigrant women to address the complications and medical challenges of female circumcision, the origin of FC, as well as the views regarding SM performance, marriage with respect to female circumcision, and finally Canadian law and on FC performance. This is really, I feel it like, it's touching somehow the cultural and family dynamic. Women's Health Bureau of the Ontario Ministry of Health assists the Horn of African Research Group in developing workshop in FC held in 1993, was titled Educating Health Professionals of Female Genital Mutilation, and had 3 main purposes. I'm gonna leave it to you guys. I'm gonna ask you a question, guys. What do you think about these legislations? To be totally honest with you. The aim, does this have any impact among circumcised immigrants who are pregnant and already they are circumcised and does not have any equal, they didn't receive optimal care of maternity care services? Does this legislation give him any help? But based on that, we can see the Canadian policies mainly aims to primary level of prevention rather than secondary level of prevention, okay? So the primary level of prevention aims to eradicate FC performance, which is great, but that not help those people who are already circumcised and pregnant. So we need to add or redirect our thinking to not focusing only on the first or primary level of prevention. We need to have both. I'm just gonna pose this very quickly. Under morality, obligation, and ethical review, did we accomplish our duty when we follow the current FC legislations? Are we moral enough among those women who are pregnant, circumcised? Just keep in mind. There is a cultural distance between the healthcare professionals and immigrant pregnant women who are circumcised. Why? The healthcare professionals' lack of cultural sensitivity toward female circumcision performance, right? Agree? Okay. Hello? Yes. Okay. Immigrant pregnant women with FG, they are afraid to talk about it, right? They are unwilling to share it within the Canadian context. Lack of understanding of the meaning of belonging, like as a Canadian, if I'm a Canadian, I'm considered those women as immigrant. They are not belonging to Canadian context. They are immigrant. We are stigmatized them as a Canadian. And I don't mean to offend you, but this is like unconsciously things. You are immigrant. You have your specific own cultural values and beliefs, but I'm not going to go there and to know it. I'm not going to share it. So this is the meaning of belonging. Circumcised immigrant pregnant women, they are also, I'm not blaming only the healthcare professionals, I'm blaming also the circumcised immigrant pregnant women because they are not willing to open this kind of social connection between healthcare professionals and themselves. So why there's dissatisfaction? Three main reasons: the lack of knowledge of female circumcision among Canadian healthcare professionals, inability to provide appropriate maternity care for circumcised immigrant pregnant women, particularly during birth, lack of cultural sensitivity among those or these women, and ignorance of their values and beliefs. This diminished the possibilities of appropriate social interaction between circumcised immigrant pregnant women and healthcare professionals. So, why? Because different language. I don't mean that different English language. I mean different expectation, different language. Like I'm talking about the cultural language, but you're talking about the clinical language. This is totally different things, right? Different health expectations, different perceptions. Like I totally have like my own perception. You have totally different mind. So we don't have such kind of connections, right? So these gonna impact on the holistic healthcare, and it's gonna be difficult to be sustained for a long time. This is a social construction thing. Those women who love social construction and theoretical terminology. We need first to consider those women as a vulnerable group. Why? Because they are pregnant, immigrant, minority, have FC, particular type 3, Somali women, Sudanese women, high risk for mortality, morbidity during natal care, decrease the accessibility and utilization of maternity care services within Canada. So they are vulnerable. And we should, as a Canadian healthcare professionals, we need to consider them as a vulnerable group, not stigmatize them. So how we can overcome these challenges, we need actually to build two things, okay? We need to develop evidences because we don't have effective evidences until now, okay? We don't know how many of those how many circumcised immigrant women in Canada. We don't have any statistics. We don't know their experiences except one had been conducted in 2001 by Chalmers and Hashi, and in 2011 had been 2010, a case study had been written, or a report had been written about the circumcised pregnant women. Only 2 studies in Canada had been conducted to just address these experiences. We are stigmatized them unconsciously. How we can achieve the optimal maternity care services, we need to develop a clinical guideline, right? But does the clinical guideline should only maintain the clinical dimensions? No, it should be maintained both, okay? Clinical dimensions and cultural dimensions. Clinical dimension needs to increase the evidence-based, okay? The cultural dimension, we need to maintain cultural competency things. So how we can maintain, like the second part of my clinical guideline, how we can maintain the cultural competency or cultural respect by develop cultural competency. How? By respect circumcised immigrant pregnant women's values and beliefs, or any immigrant population, and meet the Canadian maternity care service standards. We need to have both, right? What is the cultural competency? Cultural competency is defined as the ability to understand and work effectively with patients whose beliefs, values, and histories differ from ours. All right? From ours. Okay. So it's a process. that include critical thinking and awareness, harmonious behaviors, appropriate attitudes, manageable policies, and this is really important, come together in a system, agency, or among professionals to enable the systems or professionals to work effectively in cross-cultural situations. Why is it important in Canada? Why? We have a lot of immigrant population. In Canada, we consider as a high country that have a high immigrant population, okay? The importance of cultural competency in framing social connections, it comes through three levels, all right? Healthcare policy making levels that aims to, the ultimate goal of this one is to build a critical knowledge of mass of different cultural values and beliefs, which may use to improve and evaluate the current health policies. The second level, which is administrative levels, and here we are concentrating on the healthcare professionals and how they administer the care. And the third one, which is individual level, and that mean or aim to maintain cultural competencies to increase the self-awareness and to expect the cross-cultural knowledge between individuals, healthcare professionals, and populations. Components of cultural competency: awareness of own culture, this is number one. Number two, attitude towards different cultures, like I'm ready to accept here like my attitude to other different cultures. Third one, knowledge about different cultural practices, like after I'm gonna be ready, I need to have knowledge, right, about the different cultures. The fourth one, developing cross-cultural skills. And these are, I use these, actually I was yesterday spending like a whole night dreaming about the appropriate guidelines, but let's see. So this one actually, it's presenting my recommendations and what's the aims of this recommendation and how we can use these cultural competencies to accomplish them. And I'm going to give you an example at the end, all right? The first recommendation, redirect the current female circumcision health policies toward secondary level of prevention rather than only emphasizing the primary level of prevention. Why? It's assessing the readiness and attitudes to manage circumcised immigrant pregnant women in particular, and circumcised women in general, okay? And that's actually focused for both healthcare professionals and health policy makers. And the cultural competency, it's a critical thinking and awareness, but for ethical and moral consideration of a human rights to decide, that's a main important thing. Just I want to show you this one. This is like how we can change the current legislations from only primary level of prevention to secondary level of prevention. The FC is labeled as a crime and aggravated assault by a Canadian law as shown in the Criminal Code Bill C-119. But in case a migrant woman or a girl has experienced any type of female genital mutilation before immigration process, okay, as a result of a cultural practice, she are welcome to have two options. Either to have a repair operations or just maintain her cultural values, not repair, no cosmetic, okay? Second, the mutilated women are decided, whenever decided to perform remarrying surgery within Canada, they should not be informed, re-informed, or not allowed to recircumcise themselves again, or their daughters. If the repaired woman recircumcised herself, okay, a serious obligation gonna be taken regarding to her immigration status or citizenship. This is like an example of how we can include the both sides, like primary and secondary level of prevention, in a policy.